I'd like to now introduce our introducers for our Christopher G. Wood Rising Star Award. And to do this, we'll have first Dr. Brad Leibowitz, our chair of our board of the KCA, to come up and say a few words about this award, and then Dr. Michael Strahler from Germany, who's our co-chair for the steering committee for the IKCS this year in Europe, to introduce our awardee. Dr. Leibowitz?
I appreciate the opportunity to talk about two friends this morning. I'm not going to spend very much time, but the KCA decided that we needed to have a Christopher Wood Rising Star Award because of one of the things that Chris was passionate about. So Chris was a phenomenal surgeon. He was a wonderful friend to many of us in the room. He was an incredible advocate for our kidney cancer patients. And perhaps most importantly, he was a fantastic mentor to his colleagues for sure, but also to absolutely countless trainees. And he trained a lot of people who are very active in our kidney cancer community today. So it's only fitting that we have an award in his name to honor people that are rising stars and are the beneficiaries of his education and are now becoming mentors themselves to others in our kidney cancer community. So Chris was a friend of mine, and we spent a lot of time talking about what does it take to make a good surgeon. We had our own opinions, but we agreed on several things, which is why when I first met Sarah Suka, when she was interviewing for fellowship with us, I knew that someday she would be in the position to receive an award like this. So Michael is going to tell you all about her academic achievements, which are plentiful considering the fact that she is still a young rising star. I'm going to tell you a little bit about who she is. Sarah is in some ways could not be more different from Chris Wood, and in some ways could not be more like Chris Wood. So one of the things that I've always believed was that people who are gritty, determined, and skilled in other domains in life make phenomenal surgeons, and Sarah is that. So Sarah, you'll hear about her academic tenure, but what you might not hear about is she's a phenomenal athlete. She rowed as an undergrad, and for those of you that know anything about competitive rowing, it takes a lot of grit and determination and a lot of work and a lot of hard hours. And she brought that sort of attitude to her professional life. So Sarah's incredibly hardworking, she's incredibly dedicated, and is always looking to make herself better in everything that she does. In addition to that, you won't find a nicer person on the planet. She has, like Chris, time to talk to her friends and colleagues, time to pass on her knowledge to her friends and colleagues, and just is generous with herself around others. She's also a spouse to a great guy named Will, who is himself an accomplished orthopedic surgeon, and she's a mom to two beautiful children, Ellie and Harry, who clearly have inherited her zest for life, and it appears maybe even her athletic prowess. So I'm not going to go on anymore because talking about people that mean a lot to me like this makes me very emotional, and it'll be embarrassing if I cry in front of all of you. but I couldn't be happier to have the opportunity to talk about Sarah in the same setting as I'm talking about Chris. So Sarah, congratulations. Michael, I'll let you take over.
So on the steering committee, there was unanimous vote for Sarah. It didn't take us long to identify her as an awardee. And for those of you who haven't met her, here she is, Patricia Sutka. And I just want to run you briefly through her achievements. She is working as an associate professor of urology in the Department of Urology at the University of Washington and Fred Hutchinson Cancer Center. She received her undergraduate and medical degrees from Harvard University and completed urology residency training at the Massachusetts General Hospital. She completed the Society of Urologic Oncology Fellowship in Urologic Oncology at the Mayo Clinic and concurrently obtained her master's in clinical and translational science. Her clinical efforts focus on minimally invasive and complex open urologic oncology with particular interest in all cancerous diseases in urology. She leads the urologic oncology program at the Harborview Medical Center and is the associate program director of the UW Society of Urologic Oncology Fellowship Program. Her research focus is to study the development of personalized comprehensive risk stratification measures in patients with advanced urologic malignancies. And as I learned, she spent 10 years doing so, which is a really long and dedicated time. And we sometimes, if we see those calculators or whatever, we don't have any idea how hard it is to get there. She integrates principles of aging research, comprehensive geriatric assessments, body compositions, psychometric capital assessments in patients with advanced GU malignancies, leads multiple clinical trials in bladder and kidney cancer, and got funding from major funding sources in the US. These are her awards that she already got. It's multiple. I'm going to start at the top, and we're going to be done this afternoon reading this. She does surgery around the world. She actually went to Mongolia, which I think is pretty impressive that she did it. And I know how hard it is to do surgery just in a different OR. If it's in the middle of nowhere, it's even harder. She has published at her young age 119 peer-reviewed publications, 10 book chapters, 139 abstracts, and she has an H index of 24. There are a lot of people who are way older than her who wouldn't achieve that at all in their life. It's really impressive. She has several teaching roles. She's a mentor to over 30 fellows, resident students, and colleagues. She is a peer reviewer for most of the known journals in urology, over 25. She presented at all major uro-oncological conferences like the AUA, the EAU, the SUO, the SIU, and the IKCS meetings. She's a member of 7 guideline committees, a member of 10 grant review committees, multiple national leadership positions and responsibilities are what she does. And she is on the editorial board of some of the most esteemed journals that we have in urology, like European Urology and Urologic Oncology. So watch out what you're submitting. She might actually read it and make sure that it gets published. She founded the Women in Urology Oncology part of the Society of Urologic Oncology, is a member of the Society of Women in Urology, the Washington State Society of Women in Urology. And as you've learned, she is a mother of 2, and I can't imagine how you can do that. It's really impressive, and we're really happy, Sarah, that you are accepting the Christopher G. Wood Rising Star Award. Rising star means there's more to come, and we believe in her future, and that once she can do the surgery in our kidneys or in our bladders, and we can fully trust her and look into a bright future. Sarah.
Well, good morning, everyone. That was, thank you for those kind words. This is a tremendous honor, and I wanted to take a few words from Dr. Wood, who, to sort of lead this talk. And he always used to say in the wood fire, don't tell me what you could do, tell me what you would do. And so I want to talk about ideas and how we bring them into action. And I never had the opportunity to train with Chris, but even though I didn't train directly under him, he was someone who was a tremendous source of inspiration for me. He's a master surgeon, fierce patient advocate, innovator, and surgeon scientist, but an incredible also mentor and educator. And he was someone who really inspired me and has been somebody who I've kind of held up along with many of the people in this room as sort of the role models that I have tried to follow in their footsteps. And it's a tremendous honor to receive this award. So when Michael called me about this award, I said, well, what would you like me to say? And he said, talk about some ideas and where they went. And so I'm going to tell some stories. And he said, make it personal. And I said, okay, I'll do my best. There's not a lot of time to thank all the people who have actually contributed to all of the things that just got listed. But I do want to spend some time, and it was actually a wonderful experience to sort of have a moment to express gratitude on my own as I was thinking about how I would talk about this. So I want to tell a few stories. And the first is, when I was thinking about this talk, I actually thought about a TED Talk that I had listened to a little while ago. Emma McElroy is actually a CEO of an inclusive clothing design company, but she gave this great TED Talk on the concept of, yeah, maybe. She told a story about how when she was a little girl, she was collecting fossil rocks on the shores of a beach in Ireland. And she found something that she came up to her mom and she said, Mom, I found the toenail of a woolly mammoth. And her mom didn't say, that's crazy. She said, yeah, maybe. And they actually took it to the Museum of Natural History in their town, and it turned out it was an ichthyosaurus skull fossil. And it was the best preserved ichthyosaurus skull fossil that anyone had seen in that area. And she talks about this idea of functional fixedness and how when we have closed-mindedness, it prevents innovation. But if you say, instead of, yeah, right, you say, yeah, maybe, when someone comes up with an idea, you can really start to innovate and push boundaries. And there are a few people who have said, yeah, maybe to me more than a few times. Brad Leibovich and Steve Borgen are two of the mentors who really shaped my training when I was at the Mayo Clinic. They taught me the power of a midline exposure for kidney surgery and retroperitoneal surgery, and also helped me fill my toolbox in terms of my training with respect to getting a master's in clinical science and supporting me every step of the way. But I want to talk about one example. So when I was a resident and I had just learned that I'd matched at Mayo, I called Brad, we were talking about what we could do during my fellowship, and I said, well, what if we could give patients with small renal masses a calculator that would let them predict treatment-specific outcomes that mattered, cancer-specific and treatment-specific complications. And I think this was something that at the time, methodologically, was confusing and hard to do, but he said, yeah, so how are we going to do it? And we wrote some grants, none of them were funded, but he threw his weight behind this project that was something that was just an idea from someone who really didn't know what she was talking about, and helped me to establish collaborations with thought leaders in the field that allowed us to generate an incredible data set. Now, this took a long time, so the point up here is that I finished fellowship and we still didn't have the data set done, and went to my first job at Cook County Hospital in Chicago, then got recruited to UW and moved my family across the country, started at UW, and 10 years passed. And by then, we actually had a data set of over 5,000 patients, but it had all the muddiness of real-world data, and it took me a long time till I could find statisticians who I found at the Hutch, who could help us work our way through this. And ultimately, we did create that calculator, and it just got published 10 years after we started the project, which was a really tremendous accomplishment that for all of our team that never would have been possible if Brad had not said, yeah, maybe. And we said that a lot. We did a lot of work when I was at Mayo. We published over 30 papers, and all of that was driven by this insatiable curiosity of the mentor team that I had there and their willingness to question the dogma, what we think we know. But underlying all of that for me has always been this question about surgical candidacy. I think the hardest thing we talk about as surgeons is who should we operate on? The hardest decision we make is, should I offer surgery or not? Can you do it? Fine, but should you do it? And you know, in this day and age, patients look more like this than they do the prior. They're oftentimes medically complex. And understanding, yes, this patient's a surgical candidate versus no, they're not, is a really hard thing to do. The risk stratification tools that we traditionally utilize are vastly inadequate when it comes to discriminating patients who are good surgical candidates from those who are not. And the comorbidity indices and standardized performance tools that we use actually perform really poorly when we look at the outcomes that we as surgeons care about in our disease spaces, such as kidney and bladder cancer. And that's because these performance indices were validated for other measures and other outcomes. So it's actually really hard to estimate risk. And the limitations of our currently commonly used tools include the lack of specificity, lack of granularity, and lack of reproducibility. So what do we fall back on? We fall back on this idea of the eyeball test, which is this basically gestalt impression of fitness for treatment that comes from our experience and clinical acumen, but the problem is you can't study it. It's hard to teach, and you can't reproduce it necessarily, and we may not be as good at it as we think we are. And if we don't risk stratify well, we risk either under-treating patients or over-treating them with all of the myriad of adverse outcomes that come from that. So when I was in medical school, I heard Dr. Atul Gawande, who's an endocrinologist at the Brigham and Women's, endocrine surgeon, who many of you will know from his incredible books. I heard him speak at a commencement, at one of our commencement speeches, and he said this. He said, no matter what you ultimately do in medicine, a doctor should be a scientist in his or her own world. And in the simplest terms, this means you should count something. So where's the data? And I thought it was incredible yesterday when Dr. Mejean gave his talk, he brought up Dr. Folkman. So Dr. Folkman was one of my first science mentors. And I went to him as a medical student and said, I really want to learn how to work in a lab. And he took me under his wing and helped me to find a place in one of his mentees' lab, Dr. Joyce Bischoff, where we worked on endothelial progenitor cells and hemangioma. But he always said, pay attention, especially to the findings that you didn't expect. And so the knowledge gap here is that we need data, and we need quantitative, reliable, and validated patient-specific factors that are objective in order to risk stratify patients, in order to generate not only the need for the assessment of what we need to test next, but also to figure out what the right treatment options are for our patients so we can get our patients to the end and have them enjoy survivorship with the best possible outcome. So one of the things I was really interested in the risk stratification conversation was this topic of obesity, but the problem is the results with obesity when it came to predicting outcomes in our patients, especially with kidney cancer, were really confusing. The patients who were most obese are the patients who did the best, and this has been termed the obesity paradox. Well, what is obesity? Well, when we measure it with body mass index, it's simply weight standardized by height. But of course, if we think about body composition, it's a much more specific and different, we're talking about very, very different constructs within the same weight or BMI classification. Dr. Vicky Barakos is a researcher from Alberta who is considered the godmother of the body composition field. She and her research team validated metrics where we can use standardized routine cross-sectional imaging to estimate total body fat-free mass and fat mass. And I called her as a fellow after when I first started at Mayo and said, would you teach me how to do this? And she sent me her training manual, and Brad and the department at Mayo funded us buying this software that allowed us to do this. And over the next 2 years, I spent a lot of time measuring CT scan-based body mass, and we did this in bladder, and we did this in kidney, and we learned that sarcopenia, or a severe paucity in muscle mass, is significantly associated with increases in cancer-specific and all-cause mortality and this was reproducible across disease spaces, and we were some of the first ones to write about this. And Brad told you that I was a rower, so being a rower is kind of really integral to who I am. I rowed all through high school and then at college at Harvard. And one of the things, this is the saying that's posted on the Harvard women and Radcliffe women's rowing team locker room. It's the Rudyard Kipling quote, "For the strength of the wolf is the pack, and the strength of the pack is the wolf." When we work together, we go faster. And one of the things that I've been very lucky for is I've had incredible collaborators, and Dr. Viraj Master is one of those people who's an incredible kidney cancer surgeon, researcher, and mentor. And he and I have spent a lot of time over these last couple of years trying to understand not only how sarcopenia influences outcomes in kidney cancer, but how sarcopenia and the inflammatory milieu within a patient influences outcomes. We published a few papers on this and just published this review that sort of synthesizes a lot of our kind of key findings. We've also worked to make it easier to measure body composition and try to get past the bottleneck of how we measure body composition from routine CT images, and have a couple of videos. And I've recently gone back to working with one of the people I trained with, so Dr. Florian Fintelman, who's a radiologist at Harvard. He runs an incredible lab where they study body composition using AI, and we use artificial intelligence to automatically segment CT scans and then calculate the segmented muscle and fat masses. So we've talked a lot about how we measure form, muscle mass and quality, but of course that's simply a biomarker, a radiomic biomarker, but ultimately in the patients what we really care about is function. And I've spent a lot of time trying to make that leap and get into the science of frailty. So frailty is this global multidimensional measure of vulnerability to stressors. Cancer is a stressor, surgery is a stressor. And importantly, frailty is independently predictive of adverse outcomes across cancer stages and treatments. It's also hard to measure because there's a lot of different ways to measure it. So depending on how you measure it, the prevalence of frailty within your data set is going to be different. It's also very dynamic, and it changes across the different episodes of care for our patient. It's also modifiable, which makes it exciting as a researcher. And I spent quite a bit of time recently, especially trying to learn more about geriatric oncology and how we can leverage the lessons that have already been well defined in that space to measure frailty in our patients. And I've gotten very interested in the idea of how we can utilize comprehensive geriatric assessments to understand this multidimensional aspect of our patients. And we basically use a multidimensional evaluation of patients' health that then identifies a personal vulnerability profile. And these are actionable vulnerabilities that also is much more sensitive and specific when it comes to risk of bad outcomes, the outcomes we care about, than our traditional measures. It can actually help us to predict risks of the kinds of clinical outcomes that we need to know as surgeons and as RCC medical oncologists. And when we use CGAs in our patients, we can improve outcomes. And it improves not only the outcomes that are sort of short-term with respect to surgery survival and surgery recovery, but long-term outcomes that are salient to our patients, like their ability to live independently in their own home. But they're underutilized despite being incorporated in all major guidelines, largely because of how expensive they are, the time, and just our awareness. We're not trained to do this. Well, I spent some time in one of the first, my first successful grant was this Young Investigator Award through Beacon a couple of years ago. And during the height of the pandemic, we actually carried out CGAs in our multidisciplinary bladder cancer clinic, and we showed we could do it. It only took an extra 18 minutes, and actually it was not associated with significant burden. And a lot of patients found it very helpful to have that information when they were making their decisions. And this has directly informed an award that we just received through the National Institute on Aging, where we're going to use what we learned in that study and use a CGA that's a self-report, along with artificial intelligence-generated body composition measures, to not only learn about predictors of clinical and oncologic outcomes, but specifically this concept of functional decline with treatment for bladder cancer. I can tell you what a patient's complication profile will be after surgery, and I can tell you how long I expect them to live based on the stage and the grade of their tumor. I can't tell you when they're going to be back to making their own food and walking around and getting out of their house, but we're hopefully going to learn that with this prospective assessment. But again, so now we can generate these very comprehensive risk and resilience profiles, is what I call them. But as Dr. Wood would say, well, what are you going to do about it? And so this is where I'm at now. And so once we know a patient's risk profile, how can we modify it? the concept of prehabilitation is really exciting. It's a just burgeoning area of research, and it's this concept that where you have a process where you basically work to improve the functional capacity of a patient before a surgical procedure, so that they can withstand postoperative inactivity and treatment-associated functional decline. And there's 3 core domains, and we're going to focus mostly on the physical. There's a lot of issues with prehab adoption and scalability that are currently affecting our ability to incorporate it into our routine clinical practices, largely due to lack of availability. The fact that to date, a lot of the studies that have been done haven't been able to generate the kind of impact that we'd hoped they would. But also the pragmatism and making sure that the activity interventions, for example, are going to be appropriate for our patients, and then also cost. We can't further add to the financial toxicity of all of the treatments that we're already asking our patients to undertake. So prehab has to be pragmatic. It has to be home-based. And we really have kind of come forth with this idea at the University of Washington. I've got some amazing collaborators, Dr. Hannah Hunter, who's an incredible cancer rehab doc, and Cindy Lin, who's a sports medicine doc, where we've come up with this idea of how can we integrate exercise as medicine into our treatment paradigms. So we've come up with an idea for a home-based personalized exercise prescription that's based on a digital health solution. We create personalized exercise prescriptions and we administer them through a patient-facing cell phone-based app that's integrated with our EHR. And this is the randomized controlled trial schema that just got funded by the Bladder Cancer Advocacy Network Clinical Translational Trial Awards. We're in study startup right now. We're going to randomize patients to this pragmatic prehab intervention versus standard of care and see if we can improve not only patients' physical function, but also look at things like how does this affect quality of life and oncologic outcome and treatment-associated side effects as they go through neoadjuvant chemotherapy and radical cystectomy. And we're hoping that this is a proof of concept study that we can then scale across GU malignancies. So where we are right now is we can start to really objectively quantify personalized risk. Where we're going is hopefully thinking about how we can develop personalized rehab and prehab programs to reduce and mitigate that risk and improve surgical candidacy to, again, get patients to the outcomes that we all hope that they will get to. But of course, this isn't something that I've done by myself, and this is my so-called lab. It's my wonderful team of mentees and students and collaborators who have worked tirelessly to generate a lot of the data that has led to many of these studies. These are my wonderful collaborators, my teammates at UW, my mentors, and collaborators kind of across the country at this point. I would be missing out if I did not thank the members of the editorial board that I'm a part of at European Urology, who have really taught me a lot, and Jim Cato especially, who gave me the first opportunity to be the first woman on the associate editor board. And then after attending the Women in RCC meeting last night, I wanted to just give a shout out to what we've accomplished in the SUO in developing the Women in Urologic Oncology Association. So this is where we started in 2015. There were 14 of us. And with the support of the board of the directors of the SUO, we've grown opportunities for mentorship, sponsorship, allyship, and representation with basically the goal of bringing diversity and equity into the core cultural fabric of that organization. This was our last meeting, which was just incredible. And then, of course, my family. So these are my wonderful kids, Ellie and Harry, and my partner, William Lack, who's an orthopedic trauma surgeon, an incredible surgeon scientist, and I'll just show you how we spent our Valentine's Day operating together for the first time, which was great fun. And then, thanks to the KCA, I am humbled to receive this award. Thank you to these are just a few of the people who have inspired me along my journey, and thank you for all that you do for our community of physicians, our community of patients, and our families. And also a huge congratulations to Dr. Mejan, whose talk last night was so inspirational. Thank you.